Hello everyone, this is Alraeis from the 𝕊𝕒𝕦𝕕𝕚 Medical Center, and we're coming to you from SASIS 2024. I'm really privileged to be with the endovascular group. We had a great case today, illustration of AAA, as well as we're going to speak about some venous disease. Thanks for being with me, 𝕬𝕑 and Batool. So let's start with you, 𝕬𝕑. So you illustrated a very nice case today about endovascular therapy for patients with AAA. And you are representative of the Saudi Vascular and Endovascular Group. What is the effort done for PAD awareness in Saudi?
Actually, it's the vascular diseases in Saudi Arabia is under-recognized, especially abdominal aortic aneurysm. The prevalence of abdominal aortic aneurysm in Saudi is way less than what we think should be reported. And yes, one part because of high prevalence of diabetes, the prevalence of AAA might reduce, but when we did screening in the southern region, we found the prevalence of abdominal aortic aneurysm is not lower than what's published in the literature. Therefore, we need to do more work in the screening of abdominal aortic aneurysm, like whoever smoked more than 65 should be screened by at least ultrasound abdomen. The correlation with abdominal aortic aneurysm not only as a disease itself to be treated, but as a marker for severe cardiovascular disease, and the risk of stroke and heart attack are higher in those group of patients. Today we presented one of the cases in a middle-aged gentleman who's a smoker and not diabetic, has enlarging abdominal aortic aneurysm. He has also chronic kidney disease, where he has a concern about contrast, and it was performed with zero contrast during the procedure. But we have done contrast study just prior to the procedure by 1 month, and after procedure by 3 months, and his creatinine did not change throughout his follow-up.
Absolutely, a beautiful illustration of CO2 angiogram, high technology, as well as a good resolution and a great outcome for sure. So Batool, I'm going to come to you, Dr. Batool, talking about venous disease. And we know from studies, as we talked offline, is in any research study, always women are underrepresented. Now, I hear this is also replicated in the venous space. So can you tell us more about it?
That's true. Unfortunately, in multiple clinical trials, when it comes to medicine, not only in cardiology, women are underrepresented. And I think the more we're learning about different diseases, including venous disease, we're realizing that the physiology and the treatment plan and the prognosis of different medical conditions in women is different than men. And we need to do more research and more work when it comes to women. For example, we know that deep vein thrombosis, pulmonary embolism, different venous diseases are more common in women than men. However, no studies have been dedicated into looking into this to further understand the pathophysiology of this condition, to help us understand it a little bit more.
Yeah, in terms of therapies and the people you see, for example, May Turner, deep vein disease, and others, and DVT for sure. How is it, do you have enough the support and the screening and also the community awareness?
Sure, I think community awareness is a tough topic, okay? I work at the Cleveland Clinic in Abu Dhabi, and we have been doing a lot of changes in order to improve the community awareness, and especially work on cardiovascular risk modification in different patients, males and females. We all know that with risk modification in patients, we could definitely prevent PAD. We could prevent like limb salvage program. We have a really good limb salvage program at the CCAD. We have been working on, we actually started our first program, which is the Pulmonary Embolism Response Team. It's going to be the first program in Middle East and the MENA region. And we do believe in the multidisciplinary approach for treatment of those conditions. So teams should consist of multiple experts, because all this expertise can come together in order to provide the patients with the best possible management and treatment. It's never a one-man's job, it's always a team. So for example, in PERT, we do have vascular medicine, we have vascular surgery, we have cardiology, cardiac surgery, intensive care, pulmonary, and also outpatient clinics to make sure that those patients are followed up in outpatient settings. So I think that the key for awareness and improving those patients' prognosis is one, multidisciplinary teams that would focus on risk factor modifications for starters, and then following up with those patients to prove or help them get the best prognosis ever.
Thank you. And Mayed, I want to recap on Dr. Batool's point of the team approach. You illustrated nicely working with the vascular surgeon on the panel, but what's your in terms of working together for approaching this 𝕊𝕒? Is this something routine practice you do in your center, and this is something you recommend?
Yes, all the time. These diseases are complicated and requires multidisciplinary approach that can, at the end of the day, will help the patient to the best modality available. So it kind of three brains in one case, where interventional radiology, vascular surgeon, interventional cardiologist or angiologist or vascular medicine share together what's the best solution in cases like abdominal aortic aneurysm.
And I think this is interesting because now we just get more complicated cases. The easy one and the bread and butter kind of, I don't know what happened. Either they are prevented too early and they don't show up, and when they show up, usually have very advanced disease that require more multidisciplinary approach. Batool, you have to say something.
I also want to add that in this multidisciplinary approach, the role of primary care providers and family medicine physicians is extremely essential, because they could be the first to pick up those conditions and help them from progressing, or like catch them early so that we can prevent complications.
There's one study, to your point, by primary care just asking the question about claudication, it went up, increased the prevalence of PAD by 30%. By just asking by one question, which is just claudication and resting pain.
Exactly, or just a very simple test like an ABI.
Or ABI.
Yeah,
if that will trigger ABI and eventually lead to. Well, it was a nice discussion. Thank you, Dr. Mayed, Dr. Batool, for being with us today. This is Alraeis from SAS's Studio 2024 in Jeddah, Saudi Arabia. Thank you for joining me, and join us in next year. Thank you so much.